Good day, everyone. Today's article is titled Pain and Supplemental Anesthesia in Mandibular Molar Root Canal Therapy, a prospective cohort analysis of bone anatomy and diagnostic variables. It was done by a group from the US and was published in the Australian Endodontic Journal recently in 2026. So, achieving profound local anesthesia in mandibular molars is one of the most persistent challenges in endodontics, making the use of supplemental anesthesia strategies essential. Buccal infiltration injections are among the most commonly used supplemental techniques. However, anatomical variation in buccal cortical plate thickness and cancellous bone is hypothesized to dictate how effectively local anesthetics diffuse to the root ABCs. Additionally, pre-procedural dental anxiety often influence patient pain perception during root canal therapy. So the rationale of this study is despite the known anatomical variability of mandibular buccal bone, no prior study had evaluated the independent effect of buccal cortical plate and cancellous bone dimensions on the efficacy of supplemental supraparietal injections within the context of standardized inferior alveolar nerve block inclusive protocol. So it's a prospective observational study conducted at the University of Iowa Endodontic Residence Clinic. They included adult patients undergoing primary non-surgical root canal treatment and a mandibular first or second permanent molar performed by endodontic residents. For the clinical protocol, they administered 2 inferior alveolar nerve blocks using 2% lidocaine with epinephrine, followed by 1 carpule of 4% articaine with epinephrine as buccal infiltration, which was administered only after confirming inferior alveolar nerve block soft tissue signs. For supplemental anesthesia, they were administered if cold testing was positive pre-access. All of the patients reported pain during the procedure. Techniques included intraligamentary, intraosseous, and intrapulpal injections, given sequentially. For the outcome measures, the used patient survey included 6 questions assessing pain during injection and treatment, tooth numbness, and fear versus experience alignment, completed in private with blinding of the providers. From the electronic health record, they captured diagnosis, supplemental anesthesia type, and provider assessed anesthesia quality as good, marginal, and poor. And for CBCT measurements, they were performed by 2 calibrated oral and maxillofacial radiology residents measuring buccal cortical plate thickness and combined buccal cortical plate thickness and cancellous bone. For the results, they had 77 patients, 70% of them were females, 65% were first molars, and most frequent pulpal diagnosis was pulp necrosis, and most frequent periapical diagnosis was symptomatic apical periodontitis. For anesthesia outcome, supplemental anesthesia required in only 14% of the cases, and 89% of anesthesia quality was reported as good. For patients reported outcome, 73% reported no procedural pain, 95% reported the tooth felt numb enough, and 65% found the experience better than feared. Only 1 patient reported worse than feared, and 29% were not afraid beforehand. So the study confirmed high efficacy of inferior alveolar nerve block and the articulate buccal infiltration protocol. CBCT bone measurement showed no significant association with either pain or the need for supplemental anesthesia, and the authors attributed this partly to the inferior alveolar nerve block itself, which would already reduce the relative influence of buccal cortical plate thickness on buccal infiltration diffusion. And comparing the result with the previous studies in the literature, buccal cortical plate thickness of less than 3 mm threshold may be needed for supraparietal success without an inferior alveolar nerve block, and the current cohort's mean buccal cortical plate thickness was 2.46 mm, which was below this threshold, potentially explaining the lack of significance in the current study. However, the measurement approach in this study was at the apex level, more apical than prior studies, likely captures thinner cortical bone, making direct comparison difficult. So this study has some limitations. First, it is a single-centered study with 12 resident providers, limiting the generalizability of the results. It is a pilot study compromising independent assessment of supraparietal injections, where inferior alveolar nerve block was already included, and only 14% required supplemental use, which is a low event rate, lower than assumed, reducing the statistical power of the study. So in conclusion, inferior alveolar nerve block and buccal supraparietal articaine protocol is highly effective for mandibular molar root canal pain management, And mandibular buccal bone anatomy, which is buccal cortical plate and combined cortical and cancellous bone dimensions, was not a significant predictor of pain or supplemental anesthesia needs, and future studies should use suprapreosteal injection-only designs to isolate anatomical variables from inferior avian nerve block confounding. And thank you so much for listening.